Good afternoon, everybody, and welcome to our 2016 CPTHN webinar. Today, we have the pleasure of having Dr. Suchitra Acharya, Professor of Pediatrics and Pediatrics in Medicine at the Hofstra Northwell Health School of Medicine in New York, and the Director of the LIJ Long Island Jewish Hemostasis and Thrombosis Center, Northwell Health, and Head of the Bleeding Disorders and Thrombosis Program at the Cohen Children's Medical Center, also in New York. Suchitra is a graduate from Seth Medical College and King Edward Medical Hospital in Mumbai, India, where she did training before immigrating to the United States. Her pediatric residency was completed at Westchester County in New York, followed by a pediatric hematology oncology fellowship at Memorial Sloan Kettering in New York and at New York Presbyterian Hospital at Weill Cornell, where she continued as faculty until 2009. It was during those years that I had the pleasure of being a trainee under her guidance. During her fellowship years, she had the pleasure of working with Kathy Hager on the issue of fibrinolysis, studying annexin 2. She held several grants from NIH and NCI before moving to another area of investigation where she started to study hemophilia joint disease and translational research, now funded by the Hemophilia of Georgia. Dr. Acharya's CV is too long for us to go over thoroughly, but suffices to say she is currently the co-chair of the Anticoagulation Proteins and Fibrinogen Working Group with ATHEN, and also a board advisory with MASAC and the National Hemophilia Foundation. During her years at Cornell, she started developing an interest and also organizing and establishing the North American Rare Bleeding Disorder Registry, which is the subject of our talk today. So without further ado, I would like to thank Dr. Acharya for giving us the pleasure of having her as our webinar presenter today. Suchi, it's a pleasure to have you, and thank you very much for sharing your wisdom with us today.
Hey, thank you, Leo. I just want to make sure you can hear me and see the screen.
Very well.
Okay, great. Thank you so much, Leo, for the kind introduction. It's my pleasure and honor to do this webinar with you all, and I would also like to thank Madeline for all the audiovisual support that she's been helping me with. We trained last week, and hopefully everything should move on without a glitch. So as Leo mentioned, rare bleeding disorders has been an interest of mine for a very long time, and I consider it actually the holy grail of bleeding disorders, and I would like to share with everyone today what I have learned over the years about these very interesting disorders. These are my disclosures, none of which is relevant to today's presentation. What I will do is start off with a little bit of background, do some clinical scenarios which will enable everyone to better understand the biological heterogeneity of these rare bleeding disorders, and outline some diagnostic approaches and treatment strategies. Spend a little bit of time on rare bleeding disorder registries, which have really vastly improved our understanding about these disorders. And finally, would like to focus on girls and women with rare bleeding disorders. So a rare or orphan disease is defined as affecting less than 250,000 individuals, and the prevalence of rare bleeding disorders in the Western world is guesstimated to be in the area of 1.5 million to 1 and 1 to 2 million, depending upon which disorder you're looking at. 1.5 million is factor VII deficiency, which tends to be the most common of the rare bleeding disorders. And these rare bleeding disorders comprise 3 to 5% of inherited clotting factor deficiencies. Von Willebrand's disease and hemophilia is comprising the majority of these disorders. And in the interest of time, I think what I'm going to focus on is deficiencies of clotting factors 1, 2, 5, 7, 10, 11, 13, and the inherited platelet disorders. So this is basically just an overview of hemostasis for the trainees. I know the rest of the people are very familiar with this figure here. So we all understand that hemostasis is a well-orchestrated, tightly regulated process in the body which is triggered by vascular injury. And with vascular injury, platelets are the first cells to go to the site of this vascular injury, and with the help of von Willebrand factor, adhere to the vascular endothelium. And this requires von Willebrand factor. Subsequently, after platelet adhesion, there is platelet activation and aggregation of platelets, and eventually resulting in the formation of a primary platelet plug. And this entire process we refer to as primary hemostasis. Simultaneously with vascular injury, there's release of tissue factor, which goes on to activate the cascade of procoagulants, activating factor 7, 9, 10, 5, 2, thrombin is generated and then goes on to activate fibrinogen to fibrin, and factor 13 is actually required for stabilizing this fibrin clot. This fibrin that's generated as a result of activation of the clotting cascade now enmeshes with your primary platelet plug, eventually forming this nice tensile plug, which culminates in the reduction in bleeding that occurs. And we all can imagine that we need all these various components, both quantitatively and qualitatively, in the normal range in order to form a tensile platelet plug to limit bleeding. Although we break down hemostasis as primary and secondary, you have to imagine that in the body, this happens simultaneously. And just a quick pictorial representation of primary hemostasis. Here you have platelets migrating to the site of vascular injury with the help of von Willebrand factor adhering to the vascular endothelium. The receptor that's involved is the glycoprotein 1b receptor on the platelet surface, von Willebrand factor being released from the Weibel-Palade bodies in the endothelial cells. Subsequently, there's activation of platelets where there's change of shape, release of some of these agonists, ADP, thromboxane, A2. And this actually, the activation actually occurs also from the small amount of thrombin that's generated initially with activation of secondary hemostasis. And this small amount of thrombin can recruit more platelets to the site of this vascular injury, resulting in platelet aggregation. And the receptor that's involved is glycoprotein 2b3a, where platelets actually stick to each other and form this nice platelet plug. Just to give you a sense that there are several components in the platelets which need to be signaled at the right time to function at the right time in order to form a platelet plug. You have the glycoprotein membrane receptor where glycoprotein 1b, 2b3a complex originates. You have alpha granules, you have dense bodies or delta granules as seen in this pictorial representation here. You have the dense tubular system, and all these release components which are important in hemostasis. So you can have primary hemostatic defects depending upon where your problem is. So you can have, starting with quantitative abnormalities of platelets, which is not the real discussion of today's presentation. You have qualitative abnormalities of platelets at the level of the glycoprotein 1b receptor, which is involved in platelet adhesion. So you can have quantitative and qualitative abnormalities of von Willebrand factor resulting in von Willebrand's disease, and glycoprotein 1b receptor defect resulting in Bernard-Soulier syndrome. You can have problems with fibrinogen and glycoprotein 2b3a, which are involved in platelet aggregation. You can have receptor defects that involve all the platelet agonists, epinephrine, ADP, thrombin, collagen, and thromboxane A2, resulting in platelet function defects. There are disorders of secretion of these granules, the alpha granules and the delta granules. There could be disorders of signal transduction, decreased synthesis of thromboxane A2, which is one of the granule contents, because thromboxane A2 along with serotonin helps in vasoconstriction. So you can imagine there's a whole host of these defects that's possible, and there are a few of them which have been identified. The genetic defect has been identified, but there are a lot more which we still need to understand better. And so I would like to say that most of the platelet function defects and the information on them is in the form of case series or case reports, but something to keep in mind is that they present with mucocutaneous bleeding, and in women, menorrhagia tends to be a real challenge. The bleeding phenotype is affected by the type of defect, so whether it's a receptor-related defect, whether it's signal transduction defect, and also the severity of the defect, heterozygous or homozygous for that defect, and if it's associated with other syndromic features, and we'll discuss some of these in a little bit. Now, something to keep in mind is that neonatal thrombocytopenia, one of the most common causes of neonatal thrombocytopenia tends to be placental perturbation as well as neonatal alloimmune thrombocytopenia, and those will generally resolve within 2 to 3 months. Now, if you have persistence of neonatal thrombocytopenia beyond 3 to 4 months of age, I think it's a red flag that needs to be investigated further. In some of these disorders where these disorders are autosomal dominant in inheritance, there might be a family history of somebody with thrombocytopenia or significant mucocutaneous bleeding. Any type of mucocutaneous bleeding which is out of proportion to your platelet count is telling you something, that this is not just thrombocytopenia related bleeding, this is more a platelet function type of defect. And in that same realm, when you see a young patient with ITP who does not respond to typical treatments for ITP, you may have to keep this in the back of your mind and investigate this further. One of the main issues with diagnosing these platelet disorders is that the sample integrity affects your testing results. We all know that when you plan to test a patient for platelet function defects to do the platelet aggregation studies, there are certain things that we would tell patients, a week prior to not take. For example, medications such as NSAIDs, aspirin, would affect platelet function, so they should come off those medications. Antihistamines, antibiotics, even if the patient is sick, you always instruct patients to call you and reschedule their platelet function studies because of the fact that all these components can affect the testing results, and obviously then you will not get an accurate answer to the question. Food substances such as Chinese mushrooms, certain herbs, fish oil, ginger, garlic, ginseng are also some of the food components that can affect platelet function tests, and patients are advised to come off all these components, at least a week to 3 to 4 days prior to the testing. Other things that can affect the sample integrity is the way blood is drawn. They need to be drawn in Vacutainer tubes, in sodium citrate as an anticoagulant in the proper ratio, so you have to fill those tubes properly, and they should be transported and stored at room temperature with minimal shaking in order to prevent platelet activation, because once you activate the platelets, your results are going to be off. Also preferable to hand walk these specimens to your lab rather than tubing them. Some hospitals tend to have tubes to transport specimens, so it would be preferable to not put them in the tube system. So now let's take a clinical scenario which will be an introduction to some of these platelet function defects that we are going to be discussing soon. So a 1-day-old full-term Hispanic male presents with hematuria at birth, as well as he's covered in petechiae from head to toe. So obviously one of the things you go in and find out from the family is any kind of family history of bleeding, and that's completely normal. Maternal history is normal. She has normal menses. She had wisdom teeth extracted without any bleeding problems. She has an older daughter who's 5 years old, and she does not report any postpartum bleeding after the birth of the daughter. You do an initial bleeding screen, which includes your CBC, your coags, PT-PTTs, mixing studies, fibrinogen, and a thrombin time and reptilase time, as well as a von Willebrand panel, because you're suspecting some kind of a mucocutaneous bleeding disorder, and all these results are normal. But while you're waiting for these results to come back, you treat the baby with FFP, because FFP contains everything that you would think about in terms of any kind of coagulation proteins. And there's improvement. The hematuria resolves temporarily, but on the 4th day it recurs. And now the baby has more petechia and hematuria. At this point, knowing that the platelet count is normal, you decide to give the baby platelets, and there's complete resolution of all the bleeding symptoms. So now this is kind of a therapeutic trial, I would say, without having really a diagnosis. And, as you can imagine, in a 1-day-old, it is going to be challenging to make this diagnosis in terms of even blood draws. And so you, in your mind, when we encountered this patient, we said, yes, this patient needs to be tested for some kind of platelet function problem. This is not the right time to do this. Let the baby recover from this initial episode. And by the time, the baby is older, at 6 months of age, he presents with a GI bleed with bloody stools and drops his hemoglobin, requiring a red cell transfusion. So at that point, we send off platelet aggregation studies, and the response to ristocetin is normal, but his platelets do not respond to any of the other agonists, that is ADP, epinephrine, and collagen. And so we make a diagnosis of Glanzmann's thrombosthenia and confirm the diagnosis after sending off flow cytometry studies. So what are some of these inherited platelet defects that are well defined and which we consider a prototype for platelet function defects? So there are platelet adhesion defects involving the glycoprotein 1b receptor, which is the Bernard-Soulier syndrome. It's autosomal recessive in transmission, and it presents with macrothrombocytopenia. That is, you have a low platelet count, and these platelets tend to be really very large and giant platelets. The platelet count, as I mentioned, is low, and the bleeding symptoms are usually mild to moderate. Platelet aggregation defect is Glanzmann's thrombocytopenia, which I just described, defect in the glycoprotein 2b3a receptor, also autosomal recessive in inheritance. Glanzmann's patients can actually present very early on in life and usually present less than 5 years of age with significant mucocutaneous bleeding. The platelet counts are normal, and they generally have moderate to severe bleeding symptoms. In fact, in teenage girls and women, they really tend to have significant menorrhagia, which a lot of times does not respond to routine modalities of treatment. Platelet cytoskeletal defects involve the MYH9 related disorders such as the May-Heglen and a whole bunch of these other syndromes. MYH9 related disorders tends to be autosomal dominant in inheritance, and they can also have other associated findings such as nephritis, deafness, and cataracts, and present with thrombocytopenia with giant platelets. The leukocytes in these May-Heglen patients actually can have Dolly bodies which are present in the cytoplasm of neutrophils. They present with generally mild to moderate bleeding symptoms. Wiskott-Aldrich syndrome is X-linked recessive in inheritance. Associated findings include immunodeficiency, eczema, and autoimmune disease, which you are all familiar with. And Wiskott-Aldrich, in contrast to MYH9 type of disorders, actually you have microthrombocytopenia, really very small platelets with reduced numbers, and they usually have moderate to severe bleeding symptoms. The alpha granule defects, alpha granules secrete various agonists, and so you have 2 of them listed here, the gray platelet syndrome, which usually tends to be a milder bleeding disorder where you have paucity of alpha granules and thrombocytopenia. The Quebec platelet syndrome, described in Canada by Kathy Hayward's group, is more severe than the gray platelet syndrome, where a lot of times even platelet transfusions do not make a difference in the bleeding. So the Quebec platelet syndrome, in the megakaryocytes, there is increased urokinase plasminogen activator, and if you guys remember the fibrinolytic pathway, this UPA generates more plasmin, and that contributes to a lot of this bleeding. Platelet counts tend to be normal, but the bleeding phenotype tends to be very severe. Dense granule defects involve Hermansky-Pudlak and Chediak-Higashi syndromes, both presenting with oculocutaneous albinism. The platelet counts are normal, and these are mild to moderate bleeding disorders. And you have a delta storage pool disease, again, which tends to be a milder type of bleeding disorder. So in the diagnostic workup, obviously you will do your bleeding screen and a very good review of the peripheral smear to look not only at platelet numbers, also to look at the morphology, of leukocytes, some of which I've just described, where it may give you clues as to what your diagnosis could be. And your bleeding screen, you would send off your PT, prothrombin time, and activated partial thromboplastin time with mixing studies, fibrinogen, as well as thrombin time and reptilase time for the functionality of the fibrinogen. If you have the luxury of a platelet function analyzer, which has now replaced the bleeding time which we used to do in the old days, which could never be validated, you could use the PFA as a screening tool for von Willebrand's disease as well as the platelet function defects. Any mucocutaneous bleeding, you will need to rule out von Willebrand's disease, and then if everything is normal, there is significant mucocutaneous bleeding, you would want to do platelet function test, which is done by platelet light aggregometry. To look at some of the storage disorders, you would consider doing an electron microscopy. And once you have the identified disorder, you would want to do genetic testing to clarify what the molecular characterization of these disorders would be, because it would help to have genetic counseling, especially in disorders which are autosomal dominantly transmitted. And treatment strategies would include prevention of bleeds with the avoidance of medications such as NSAIDs, which along sometimes, in disorders where you have thrombocytopenia, it would be a double whammy, causing both quantitative and qualitative abnormality of the platelets. Good dental hygiene, control of menstrual bleeding with hormones and other modalities, prevention of epistaxis with moisture therapy, as well as control of allergies. A lot of patients with allergies tend to have significant epistaxis, and that needs to be better tuned in patients who have mucocutaneous bleeding. Treatment would be, for epistaxis, would involve using, pressure and the use of inert polymers, topical thrombin, and packing sometimes, cauterization. Dental procedures, apart from replacing either platelets or other agents, which we will talk about in a second, would also involve good local hemostasis with fibrin sealants and collagen. Antifibrinolytic agents tend to form the mainstay of therapy in a lot of these inherited platelet disorders, especially prior to dental procedures and for treatment of any of the mucosal bleeding. So two antifibrinolytics that we use, aminocaproic acid and tranexamic acid, because areas such as the nose, the mouth, the uterus, prostate tend to have an abundance of fibrinolytic enzymes. So antifibrinolytics really, for some of the milder platelet function defects, they form the mainstay of therapy, and you would want to keep other things in reserve, such as platelets, which ideally would treat any of these disorders. When you do decide to use platelets, it would be preferable to use HLA matched platelets or single donor platelets. One of the biggest problems with the use of platelets is allergic reactions and alloimmunization. And once you do form these alloantibodies, it's really a big problem and very challenging to treat these bleeds, and therefore you would try as much as possible to avoid the use of platelets. Again, this needs to be weighed depending upon the type of bleed, depending upon the type of surgical procedure. You could potentially consider using maybe one dose of platelets before the procedure, followed up with some of these other agents. DDAVP has been found to be effective in patients with storage pool disorders, and there's a variable response with Bernard-Soulier and the MYH9 related disorders. The Glanzmann's patients really do not respond to DDAVP. With the Glanzmann's, there's more recent experience with the use of recombinant 7A, and doses that we use are similar to the doses we use for hemophilia inhibitor patients, and generally, is one of the components in treating these Glanzmann's patients. As you can imagine, they are sometimes very difficult to treat. Splenectomy and bone marrow transplantation has been effective in patients with Wiskott-Aldrich and Shediac-Higashi syndrome. Now switching gears to discussing procoagulant deficiencies. These are, I think I already mentioned what I'm going to be focusing on, some of the procoagulants. I would just like to go over some of the case scenarios. An 18-month-old female is admitted to the ICU because she has viral myocarditis, and during her hospital stay, she develops hepatitis and DIC. She has a central line placed, and she develops a deep vein thrombosis. And during investigating as to what could the etiology be, despite the fact that she is in an ICU, she has a central line and has been very sick, you send off a thrombophilia workup, and her PT and PTT are mildly prolonged, and all the factor levels are normal, except for a fibrinogen, which tends to range from 17 to 70. So the initial thought is, she probably, this is DIC. Even after recovery from a DIC, her fibrinogen is always, uh, in the low range. And she is referred to us, and we work her up to find out that her fibrinogen is still, in the 40 milligram per deciliter range. And so send out a fibrinogen antigen, and we find out that the fibrinogen antigen is normal. And so she is diagnosed with dysfibrinogenemia. Interestingly, her mother, who is going to be a donor for her own mother for a kidney transplant, also gets worked up and has an extremely low level of fibrinogen. Likely she also has dysfibrinogenemia, which tends to be autosomal dominant in inheritance. This dysfibrinogenemia group of disorders are really very interesting. About 50% of these patients are completely asymptomatic, like the mother of this child, and probably this child too. If she hadn't gotten sick with the myocarditis, she would never have been diagnosed. About 20% of these patients tend to have a bleeding phenotype, and 20% actually have a thrombotic phenotype. So these are all very interesting, disorders. A 22-year-old male presents with a right hand bleed to the emergency room, and he reports a history of skin as well as muscle bleeds. He had an appendectomy at age 10, and he had wound dehiscence. He reports that he generally bleeds with trauma. He's never had any joint bleeds. He has a younger sister who has presented with several episodes of mucocutaneous bleeding, significant menorrhagia, and has had 3 spontaneous intracranial bleeds. So when he's worked up, he's found to have an extremely prolonged PT as well as PTT. His fibrinogen activity as well as antigen are undetectable, and he has prolonged thrombin time and replase time, confirming his diagnosis of congenital afibrinogenemia, which is also genetically confirmed. He has a frame shift mutation in the FGA component of the fibrinogen gene. So you can see here that siblings with the same genetic defect present with completely different symptoms. And so this is something we always have to keep in the back of our mind when we are considering replacement, more in terms of prophylactic replacement of clotting product, so that you don't really, tip the balance towards thrombosis. A 3-day-old female presents with seizures and lethargy. CT scan reveals a massive intracranial hemorrhage, and she's brought to the OR for evacuation, but she's continuing to bleed despite the evacuation. And at the time you notice that her umbilical cord is attached and it is oozing, and there's no significant family history of any kind of bleeding. And her CBC, her coags and fibrinogen are completely normal. So when you have somebody, especially a newborn, with a massive intracranial bleed with normal coagulation parameters, I think it's mandatory to rule out factor 13 deficiency, which was sent in this young girl, and a factor 13 activity was undetectable. And the diagnosis was also further confirmed. She had the factor A subunit that was missing. Factor 13 has an A subunit and a B subunit, and the A subunit is the more common one, occurring in about 90% of factor 13 patients. Another case, a 7-year-old female who's a ballet dancer complains of bilateral ankle arthritis, and she's had x-rays done, which confirms, that she already has changes in her ankles. She reports, the parents report one episode of significant oozing after dental extractions. Her 9-year-old brother developed severe ankle hemarthrosis after playing soccer, and he's had history of significant epistaxis. Her coagulation studies reveals prolonged PT with a normal PTT, which corrects on mixing, and her factor 7 level, when you do the PT-dependent factors, is less than 1%, and both these siblings have a diagnosis of congenital factor 7 deficiency. So as you can see from these various case presentations, each one has a different clinical presentation. So what are some of the characteristics of these rare bleeding disorders? They are mostly autosomal recessive in inheritance, so generally there may not be a family history, except for factor 11 deficiency, which tends to be autosomal variable, and the dysfibrinogenias are autosomal dominant. They're definitely more common with consanguinity, which we'll discuss in a little bit. The most common of these rare bleeding disorders are factor 7 and factor 11 deficiencies, and factor 2 deficiency is the least common. And something to always understand in hemostasis, and more specifically with the rare bleeding disorders, is that the overall hemostatic balance is more important than an individual factor level. Because when we tend to test these patients with bleeding symptoms, we a lot of times focus on that one clotting protein which is low. You have to imagine and understand that this clotting protein needs to interact not only with other procoagulants, there are anticoagulants, fibrinolytic factors, some acquired risk factors, and the eventual phenotype is an interaction of all these different components. And so we cannot just rush into replacing sometimes these clotting factors in these patients just because one of these clotting factors is low. And I think it's really important to pay attention to the bleeding or the clotting symptoms in these individuals. Bleeding risk is generally unpredictable in factor 7 and factor 11 deficiencies. With the other rare bleeding disorders, there is somewhat a rough correlation between levels and bleeding symptoms. In children, something to keep in mind is that when you do a venipuncture in an emergency, there is contamination from tissue factor, which can actually normalize your results. So sometimes it's important, if the patient is having ongoing significant mucocutaneous bleeding, to repeat these tests, especially when they are more stable. To contrast with the hemophilias, hemophilias and von Willebrand's disease account for 90% of all inherited coagulation disorders, whereas rare bleeding disorders are comprised 3 to 5%. Hemophilias are X-linked recessive in inheritance, whereas these are predominantly autosomal in inheritance. There's family history in male relatives for hemophilias. Here, family history is really often lacking, except when there is consanguinity in the family. You may be able to identify other family members with similar factor deficiencies. Hallmark of hemophilic bleeding is soft tissue and musculoskeletal bleeding. It's mucocutaneous bleeding with the rare bleeding disorders, and even that presentation could be highly variable. Clinical severity generally correlates with your clotting factor levels with the hemophilias, and that is why we classify them as mild, moderate, and severe. Whereas with the rare bleeding disorders, there's really very poor correlation between levels and the bleeding symptoms, especially with the factor 5, factor 7, and factor 11 deficiencies, where bleeding symptoms generally do not correlate with factor levels. So important to focus on bleeding history, especially atypical bleeds such as hemarthrosis can occur, retroperitoneal bleeding, intracranial bleeding can occur. Menorrhagia tends to be a challenge in these patients, and bleeding after hemostatic challenges. Bleeding that you can see in the newborn period that you would sometimes see is umbilical stump bleeding, which tends to be pathognomonic of factor 13 deficiencies. A lot of these rare bleeding disorders in the homozygous state can present at birth with significant intracranial bleeding, and you can get bleeding post-circumcision, after heel sticks, after intramuscular injections. Bruises, and especially palpable bruises in a child who's not independently mobile, should be a red flag. And also in an older mobile child, if you have persistent palpable bruising, that needs to be investigated further. Fibrinogen disorders, factor 7 and factor 11 deficiencies, actually can also present with thromboembolic events. And this is something that also needs to be recognized, especially in the setting of replacement therapy. Quickly, these are some of these palpable bruises, as you can see in the shins. Strep throat infection causing tonsillar bleeding, which occurs, in these patients. And intracranial bleeding and hemarthrosis has been described in most of these rare bleeding disorders, except for factor 11 deficiency, where there is really no documented case report even of intracranial bleeding or hemarthrosis. Okay. And so how do we classify these disorders now that there's really no good sense of how the clinical presentation is, and factor levels do not really help us in classifying these disorders? Saurabh Paivandi, who is actually an international leader of rare bleeding disorders from Milan, Italy, established the European Network of Rare Bleeding Disorders. And when they looked at their data, they came up with this clinical bleeding grading, and that I think has been the most useful in classifying these patients. So you could be asymptomatic. Grade 1 bleeding was defined as bleeding that occurred after trauma or consumption of antiplatelet platelet agents or anticoagulants. Grade 2 bleeding was spontaneous minor bleeding, predominantly mucocutaneous bleeding, and grade 3 bleeding was spontaneous major bleeding, including joint, muscles, CNS, GI, and umbilical cord bleeding. And they also found that you tended to have severe bleeding symptoms when clotting factor levels were less than 10%, or with fibrinogen when the level was below 20 milligrams per deciliter. So this table further defines individuals who could be asymptomatic at these cutoff levels, as well as grade 3 bleeding, which has occurred in rare factor deficiencies with levels less than 10 to 15%. Factor 11 deficiency is unique. As you can see here in this slide, you could be asymptomatic at 26%, and at less than 25%, you could have a grade 3 bleed. And so really with factor 11 deficiency, I still don't think we have a good sense of how to predict bleeding in these individuals. And diagnostic workup would increase your bleeding, would include your bleeding screen. The only other difference is when you send off factor activities, you always have to send off factor antigens, because with the rare bleeding disorders, you not only get an aproteinemia, you can also get dysproteinemia. So you really need to understand that difference, because with dysproteinemias, it's a qualitative defect in the protein, and these are some of the patients who may tend to have a thrombotic phenotype, especially as you can see with the dysfibrinogenias. You could then send off for molecular testing to identify the mutation, and again, mutation identification, I think we have the most data from the fibrinogen group of disorders, where they've been able to correlate certain mutations with the bleeding phenotype, with the clotting phenotype, and also some of them being asymptomatic. More recently, there has been an interest in looking at the bleeding assessment tools of the ISTH, which has been validated for von Willebrand's disease. Thrombin generation assays are something that people are looking into to better define the bleeding or clotting phenotype. And there's also work being done to look at fibrin network density using confocal microscopy in these disorders. I just wanted to point out a little bit of data here using thromboelastography for rare bleeding disorders. This is a fairly recent publication. If you look at panel B here, this is for a patient with Glanzmann's thrombasthenia. I know these colors are probably light, but I hope you can see at least the peaks of these thromboelastograms here. The purple one is the control. The red and the green ones are two patients with Glanzmann's thrombasthenia. As you can imagine, there's barely any thrombin that's generated. The panel C is a patient with factor 7 deficiency. Here, the red is the control here, and the green curve here is a patient with factor 7 deficiency who actually had multiple intracranial bleeds, and purple and blue curves are other patients with factor 7 deficiencies. The last panel here, the D panel, is patients with factor 13 deficiency, where your purple is the control, and the blue curve is a patient who's is symptomatic, actually developed an intracranial bleed. So as you can see, there's definitely significant differences between controls and patients, and also between patients and with mucocutaneous bleeding and those with significant other bleeding. So this is a tool that really still needs to be standardized and then validated, and could be a useful tool for rare bleeding disorders given their biological heterogeneity. I'm not sure, in the interest of time, I think we'll skip the slide. This is basically diagnostic approach to working up prolonged PTs and PTTs, which hopefully all the trainees are familiar with. Just want to put up this slide here. In this day and age, in 2016, we have single factor concentrates, either plasma derived or recombinant, available to treat all these disorders except for factor V deficiency, which is still treated with FFP. For factor 11 deficiency, there's a concentrate that's available in Europe. And so in 2016, you will use single factor concentrates or prothrombin complex concentrates, which are used for factor 2 deficiencies, as first-line therapy, reserving FFP and cryoprecipitate only as second-line therapy when these are not available. Treatment strategies, as I pointed out earlier, depends upon the type of factor deficiency and the severity of the deficiency, and also the bleeding phenotype. If you have somebody with a low factor 7 level, for example, say you have a patient with a factor 7 level of 37%, and this patient has never manifested any bleeding symptoms and is going for dental extractions, we generally would not consider doing anything, because a lot of these factor 7 patients tend to be asymptomatic. I think we still don't completely understand why that's the case. In fact, there's a small subset of factor 7 patients who have a thrombotic potential. So you really have to be careful with replacement therapy. So dental extractions, it's not something that's a major procedure. You could get away by not treating them and making sure there's access to at least an antifibrinolytic, aminocaproic acid or tranexamic acid, and you'll advise the patient to take this antifibrinolytic if there is any bleeding, and then to call you, and then you can decide if you need to, give this patient recombinant factor 7A. Also, replacement, you would want to consider half-life of the factor, especially if it's a surgical procedure. It's good to do a PK study and determine the patient's half-life, minimal hemostatic level, the type of bleed, because you will need to decide how long to replace. And typically, like in hemophilias, we replace clotting factor concentrates until the healing is complete. There's a role for prophylaxis in some of these rare factor deficiencies for intracranial bleeding and for recurrent hemarthrosis. For factor 7 deficiencies, for fibrinogen, and for factor 13 deficiencies, especially during pregnancy, because factor 13 and fibrinogen are required for implantation. And of course, pre-dental and pre-surgical, depending upon the type of surgery. A lot of times, for example, for patients with factor 7 and factor 11 deficiencies, you can get by just using antifibrinolytic agents and not even requiring the use of factor concentrates. Now, the quest for the Holy Grail in the last few minutes, because I think really we need to understand these disorders better. And a lot of our information actually has come from the European Network of Rare Bleeding Disorders and a survey that was done through the World Federation of Hemophilia, and data contributed to by over 108 countries. And as you can see here, factor 7 and factor 11 tend to be the most common, followed by factor 10 and fibrinogen deficiencies, and your factor 2 deficiency is the least common of these rare factor deficiencies. Interestingly, in Iran, Italy, and the UK, there have been registries for these rare factor deficiencies, which have really, I think, improved our understanding, given the fact that they are rare. No single center or country has the number of patients to actually understand these, the presentations and the heterogeneity of these disorders. So if you look at this blue outline box here, the prevalence of hemophilia, hemophilias in Iran, Italy, and the UK are similar. But if you look at the prevalence of these rare factor deficiencies, they tend to be a lot more prevalent in Iran as compared to Italy and the UK. There is a 3 to 5-fold higher prevalence in Iran. And why is this so? If you look at this slide, you can see that there is a high rate of consanguinity in Iraq, Iran, Pakistan, Turkey, Egypt, and the southern part of India. In fact, the rate of consanguinity in these places ranges anywhere from 40% to 80% in the small community in southern India. And this translates into a 3 to 7-fold higher prevalence of rare bleeding disorders because of the higher rate of consanguinity in the Middle East and Southeast Asia as compared to the developed countries. And so what happens in these nations? Culturally, it's normal to have cousin or uncle-niece marriages, and there's always a social pressure to marry earlier, increasing the reproductive lifespan, and so a lot of children are born. They are generally, we talk about rare factor deficiencies as being autosomal recessive in inheritance, but when you have consanguinity, the prevalence actually approaches that of the hemophilias. And so now in India and Iran, there is development of genetic services in order to identify these families and to provide genetic counseling to reduce, the impact of these rare bleeding disorders. Now, the real big dilemma for individuals with rare bleeding disorders is because of their heterogeneous presentation, a diagnosis is really very difficult. Clinicians really a lot of times miss these diagnoses, and this is further compounded by the fact that our laboratory testing for these disorders is not black and white. And even if they are black and white, even if you do pick up some of these rare factor deficiencies with low levels, it doesn't necessarily mean that they will bleed. Also, centers who take care of these patients with rare bleeding disorders, typically, hemophilia treatment centers, really have a small number of these individuals. So it's really, again, difficult to come up with, definitive diagnostic and therapeutic strategies. And for some of these factors, like factor V, we really still don't have specific replacement therapy. So this really, translates into becoming significant challenges for patients with these disorders. So the World Federation of Hemophilia Survey, the European Network of Rare Bleeding Disorder database, has really improved our understanding of these disorders, but we still have a long way to go. ATHEN, which is the American Thrombosis and Hemostasis Network, has a rare bleeding disorder database for which the data collection is ongoing, and the European network is now looking at prophylaxis for these rare bleeding disorders. This is a very useful resource, the Rare Coagulation Disorders Resource Room, which has been actually funded by the Indiana Hemophilia and Thrombosis Center, and I would definitely recommend anyone interested in rare bleeding disorders to go to this website, since there's information on each of these disorders and detailed information, both clinical as well as information on individuals who are interested in research for these rare bleeding disorders. And finally, I'm just going to quickly highlight some of the problems for girls and women with rare bleeding disorders. So the World Federation data provided us the gender distribution of these rare bleeding disorders, and as you can see here, it's half and half. And girls could present at birth with umbilical cord bleeding, intracranial bleeding, any kind of mucocutaneous bleeding, but predominantly a lot of them will present during adolescence, at the first period, menarche, or can have chronic or acute anemia. Menorrhagia incidence has ranged anywhere from 40 to 70% depending upon the study you're looking at. Bleeding associated with rupture of the corpus luteum has also been reported, and hemoperitoneum. Really, no female should have hemoperitoneum during menses because it's usually a disorder related to trauma, but when you have spontaneous hemoperitoneum, it should be a red flag in a teenage female who's menstruating to look for a bleeding disorder, and specifically for a rare bleeding disorder. So we do assess menorrhagia in our clinics with the use of these PVAC charts, pictorial bleeding assessment charts, where points are given for the pads or the tampons that are saturated or not saturated. And the PVAC chart has been in use since the 1990s in the UK and has a pretty good correlation with menorrhagia. The bleeding score more than 185 actually correlates very well with menorrhagia, with a positive predictive value of 85%. This bleeding score has also been used in factor VII deficiency, where bleeding scores over 100 correlated significantly. and in another study, higher bleeding scores correlated with excessive bleeding at menarche, menorrhagia, and in general, any kind of general bleeding symptoms. Pregnancy is a physiologically hypercoagulable state, but the bleeding risk in women with rare bleeding disorders is still present. Miscarriages have been reported in factor 13 and women with afibrinogenemia, because both these factors are required for implantation. Placental abruption can occur. Postpartum hemorrhage, both immediate as well as delayed or secondary PPH, has been reported. And in the fibrinogen group of disorders, thromboembolic events during pregnancy also should be kept in the back of your mind, especially if you're going to be replacing these women during pregnancy to prevent bleeding. So ideally, women with rare bleeding disorders, when they are pregnant, should be cared for in a bleeding disorder center or hemophilia treatment center in conjunction with a multidisciplinary team, including the hematologist, the obstetrician, anesthesiologist, primary care physician. There are no specific guidelines for epidural anesthesia during delivery, and a lot of this is extrapolated from the guidelines we use for hemophilia carriers, that is maintaining levels over 50% and maintaining that at least 12 to 24 hours after catheter removal. Always need to keep in the back of your mind postpartum hemorrhage. The type of delivery, vaginal versus C-section, should be something that should be safe for both the mother and child. These women tend to be at risk for late postpartum hemorrhage, so make sure a CBC is checked before discharge, and women are counseled about their bleeding risk, and they should report prolonged bleeding and follow up sooner if they do have prolonged bleeding. Disorders which are at risk for thrombosis, the fibrinogen group of disorders, factor 13, really need to be carefully weighed when you are replacing, using replacement factor concentrates to prevent bleeding, because thrombosis given pregnancy, postpartum state is obviously a concern. Sometimes when a patient has had a bleeding phenotype and you know you need to replace these women post-delivery, it would also help to use clotting factor concentrate along with an anticoagulant to prevent thrombosis, and identifying carriers so they can be appropriately counseled. For the newborn, avoid forceps vacuum. Again, recommendations which are similar for what we do for hemophilia. C-section in order to avoid intracranial hemorrhage and cut short the second stage of labor. If it's feasible, send the cord blood to test for factor levels and do a screening head ultrasound to rule out an intracranial bleed. And keep in mind, intracranial hemorrhage can be delayed even after discharge, so the mother needs to be educated on reporting symptoms of raised intracranial pressure. Avoid intramuscular injections, heel sticks, and elective procedures as far as possible. And once a baby is diagnosed in the newborn period, make sure to refer them to a bleeding disorder center, a hemophilia treatment center, centers which are familiar with taking care of these patients. And my final slide, always pay attention to prolonged mucocutaneous bleeding and think about platelet disorders, factor deficiencies. If your workup is initially normal, repeat the testing, because this is what happens given the difficulties with our assays. Also test family members. Maybe sometimes a family member you would pick up who would be on diagnostic testing, and you would be able to explain the mucocutaneous bleeding. Palpable bruises need to be investigated. Iron deficiency anemia and recurrent hemoperitoneum in menstruating female needs to be investigated further. The clinical bleeding phenotype is a lot more important than a factor level, as discussed earlier. And a moderately prolonged PT-PTT associated with bleeding is a lot more relevant than a mildly prolonged PT-PTT where there are no bleeding symptoms. Pay careful attention to sample collection as well as the processing, and once you do have somebody with prolonged bleeding, referral to a bleeding disorder center, and this specifically goes to pediatricians who are the gatekeepers and patients who first encounter some of these patients with rare factor deficiencies. And I would like to thank you all for your attention, and thank Leo Brandau and the sponsors for giving me this opportunity. Thank you very much.
Thank you very much, Suchitra, for this fantastic comprehensive review. Let me ask the CKids audience. I will keep their questions to the last one, and when you do, please come to the white microphone to do so. Let me go straight to Alberta Children's to see if there is any question from there. Is there any question from Alberta Children's? Their mic is open, but we don't hear any questions from Alberta Children's. Then let's go directly to Chio. Do we have any questions from Chio? No questions from Chio. Let me go to Montreal. Jennifer or anybody from Montreal, any questions from there? Let me unmute the microphone in Toronto then. Oh, actually there's a question. Let me go back to Alberta. No questions. My apologies. Let me open the mic in Toronto. Toronto, the floor is yours. Any questions?
No questions, Leo. It's very clear. Everything was excellent. Thank you.
I think I heard no questions. Suchi, maybe I have a question. You've said that it's difficult for us to distinguish symptoms based on numbers. Sometimes we're left with not the patient that bleeds a lot, but the patient that not necessarily has a lot of symptoms, but then we question ourselves, do we give factor? Do I don't give factor? If I give factor, it may cause thrombosis. Do you have any pearls? I know you've already shown several pearls throughout the presentation, but any other comments that could be useful for clinical management on these challenging patients whose phenotype, meaning the number of the level, circulating level, doesn't necessarily answer the question?
That's an excellent question, Leo. And, we go back and forth with a lot of these patients, especially the factor 7 patients where, they're the ones you see routinely for in pre-surgical testing, for no good reason, surgeons tend to send out coags, which, I always say, don't send out coags, take a good history. So, yeah, that's really a very challenging question. So what we've been doing in general, I would say, is let's say the level is anywhere between 25 and 50%, whatever the lower range at your laboratory is. If the patient really hasn't had any bleeding symptoms, there is no significant family history of bleeding, and it's a relatively minor procedure, say, for example, it's a dental extraction or it's a circumcision, I would generally say don't do anything. You clear the patient and make sure that they have access to an antifibrinolytic agent, aminocaproic acid or tranexamic acid. And if there is any significant bleeding, they should take a dose of that and call you. And at that point, you can consider replacing, whatever the particular factor deficiency is. Having said that, I think we still need really, better tools, both clinically as well as laboratory-wise. So maybe thromboelastograms in the future may be something to, look into in some of these patients. And once you've actually demonstrated that they barely generate any thrombin, those are the ones who are going to have problems with surgical, procedures. And those are the ones you may consider replacing prophylactically when they go for a surgical procedure. Does that kind of make a little bit of sense? I know this is, again, not based on any good data, unfortunately, but this is where we, stand.
Yeah, no, very, very helpful. I think in the interest of time, maybe we will close this fantastic webinar, and I'll remind the audience that on January 31st, this will be followed by Dr. Mark Crowder, who will be talking about reversal of direct oral anticoagulants, state of the art. Thank you very much for your attention. We wish you a happy holiday season, and we'll reconvene in January. Thank you again, Dr. Suchi, for being so kind and for teaching us through the sea of rare bleeding disorder. Thank you again.
Okay, thank you, Leo, and happy holidays to you and to everyone in the audience. Okay, take care.
Likewise. Thank you.
Yeah, bye-bye.